it seems like there's a push to move from kind of an acute care model to a chronic model, which I again believe in. But the privately held insurance companies are still very much entrenched in this acute care. So there's hospitalization coverage, but then nothing. Does the state have any leverage over privately held insurance to push them to move towards a more chronic care model?
So the biggest challenge that we have in Michigan, we have so many of the plans that are either federal ERISA plans or they're self-funded plans, and our ability as a state to regulate them is very, very small. Like we don't get to do that very often. So even if we do pass like the autism insurance reform, we pass basically a mandate, but it only applies to those insurance companies that we can actually control, which is a very small part of our whole overall population. But we can do a few things, right? So we control a lot of healthcare dollars in the state because through Medicaid and some of the other programs that we fund and support, the Children's Health Insurance Program, the Healthy Kids Dental, like all these programs, we can really encourage providers in a lot of ways with the power of our contracts and the power of the investments that we make with our resources. And so that's why one of the pilots in here is a bundled payment pilot, because when you're talking about every aspect of care, whether it's, and again, it's not being done yet in very many places for behavioral health, but if we have a population that we know, and we've got a couple in mind that we want to try this with, that we know they're going to need care for their ongoing diagnosis. They're going to get colds. They're going to get the flu. They're going to need other kinds of. In the bundled bundled payment contract, it's for their care for the entire length of the contract for whatever care is needed. So hospitalization time, if needed, 100%. Office visits, therapy, whatever. And it'll be really interesting. It's one of the programs that has some private foundation support as well. There's some private foundations around the country that want to support this work, and I think it will change the way that we approach this work, because one of our biggest costs in another program, say like the dual eligible program for our citizens that are both Medicaid and Medicare eligible, readmissions to the hospital and length of stay in the hospital is a big cost driver. But if you can do to help those people who don't need to be in the hospital, keep them out, and free up the sort of dollars for people who do need more in hospital care, we'll still see savings. So I think that's one way we can start to, again, with our contracting, we can start to push people to do things differently. And when you show results, which is the same thing we wanted to do with autism, we couldn't mandate that any of the ERISA plans or the self-insured plans do the same coverage that we're doing in Medicaid and that we're doing with our state-based insurance plans. But we created in the first few years a pot of money for reimbursements for those companies that decide to do it. So we'd basically help them pay for it for the first few years of the program. And the idea is that once people start covering it, they will continue to cover it, and that there'll be also the sort of citizen pressure to cover it. If my neighbor's plan has it, why doesn't my plan have it? And talking to your benefits administrator about why it's not in your plan. So it's not as smooth and direct as us being able to say, you have to do it, you have to follow our lead. But we're a big part of the healthcare dollars in the state, and if we do it, it will start to change the game.